Thank you for the kind introduction and the invitation to speak today on the last day of the Bangkok Symposium for this year. And I'm going to share with you my thoughts on the advances in the pediatric antiretroviral pharmacology. Here you can see my disclosures, and I would also like to disclose that I shared a draft version of the presentation with some of my colleagues who are also here in the room. Annette Zoon from TIT Asia, Tim Quessy from Chiang Mai, some colleagues from HIV-NAT. So if you don't agree with anything in the presentation, you can go to them. Okay, thank you. So what I'm going to do is to give you a short historical overview of pediatric antiretroviral pharmacology, just to get you a little bit aware of where we used to be a few years ago and where we are now, and to see that change. And I think that a large part of that change can be explained by the introduction of dolutegravir. You have heard a lot about this drug already, but now we talk about the pediatrics, and I think it's a game changer, and I will explain that to you. Still, we have some knowledge gaps with the dolutegravir implementation. I will discuss them with you, and one or two slides on maybe future improvements that hopefully we will see in the coming years. And I will end with some conclusions. So when I was starting the preparation of my talk for today, I thought back about another presentation I gave already in 2015 at the ICAC conference in San Diego, so about 7-8 years ago. And I was asked to give an update at that time about the antiretroviral treatment in pregnant women, but also in children. Of course, now talk about children. And the subtitle was Challenges and Successes. Well, if you think back about 2015, you could really calculate some of your successes already, because in 2015, at least in high-income countries, we had a total of 18 drugs available for children. Of course, that was not true for every country in the world, I realized that, but at least in some countries we had this relatively large number of antiretroviral agents available for treatment of children. So that's clearly a success if you then compare with the years before 2015. However, not only successes, there were also some disappointments and some challenges noted. This is a table that I had in my presentation in 2015, where I was comparing the date of the adult approval and then the same date, but then for the pediatric approval. You can just see some of the drugs mentioned here. That is quite a long time, sometimes even 10 years or 8 years between adult approval of an agent for HIV and pediatric approval. So that means that there's a significant delay in getting these agents available for treatment of HIV-infected children. So that's not good news, not at that time. And another way of looking at the same problem is that if you make a comparison, and I did that in 2015, of the adult treatment guidelines from the US and the pediatric treatment guidelines also in the US, there's zero overlap between these two guidelines. So we are recommending agents in children that are no longer in use in adults. So that's a very sharp contrast how far we had gone at that moment for the treatment of children with HIV. And I was not the only one who was a little bit disappointed about it and pessimistic or negative about it, critical, you could also say. This is also from a few editorials in journals around that time. And you can read the titles, Children, Are We Doing Enough? Well, question mark. And also maybe even more critical, an editorial that was titled Failed Pediatric Drug Development Trials. So we had some improvements, but clearly not enough. And I think that it really has changed over the last couple of years. And the main results, the main reason for that, I think, is the introduction of the dolutegravir. And I call it a game changer. We have seen the first pediatric approval by the FDA of a formulation for children above 30 kilograms, which was only 3 years after adult approval. So relatively soon if you compare it to the other agents in the past. And there were two different film-coated tablets for children, 10 and 25 milligram. And you had to give the dose of 35 milligram of that film-coated tablet once daily. Also, another important difference when you compare it to the past is that in the label of dolutegravir for children, now the weight bands that were developed by the WHO were presented. And I think that's a very important new way of looking at dosing of medications for children. It used to be in the past on age, so higher than 6 years or between 2 and 6 years, for instance. But now it's on weights, which makes much easier and also, I think, better predictable what you get for exposure to drugs. And then a few years later, in 2020, there was a new formulation, so a second pediatric formulation developed by ViiV Healthcare, which were dispersible 5 milligram tablets. And also an important change happened around the same time that based on studies, and I will show you some of the results, we could change the dose of the film-coated tablets to the adult dose of 50 milligram already in children above 20 kilogram. So that shows that already relatively young children with a body weight of 20 kilogram or higher, they can get the adult dose. And if you in a country only have the adult formulation of dolutegravir available, then you can already treat the children once they are 20 kilograms or more. And that has resulted that the first pediatric formulation of the film-coated tablets in 10 and 25 milligram nowadays in high-income countries are discontinued. So we have seen also the replacement of one pediatric formulation by another one. And the data that has had an enormous influence on that came from the Odyssey trial that was published in Lancet HIV 2020. And I think that when I will be retired and I will look back at my career, this is certainly one of the trials that has the biggest impact on treatment of patients with HIV that I've been involved. And we got several awards from the EX. We got a national award, a PhD student, Pauline Bolle, is there. And we get a local award from the University of Nijmegen for our work on Odyssey. So what you can see in this graph, just one summary of the various doses that we gave with the various formulations. So this is dispersible tablets, this is film-coated tablets, and you see the different weight bands, around 10 or sometimes more patients per weight band. And we all looked at the 24-hour pharmacokinetic curves for dolutegravir. We used the adult reference of 50 milligram once daily, and we needed to be sure that with the trough concentrations, we should be more or less similar to that value. You can see that with some of the formulations in some weight bands, we were not that successful, so we ended up a little bit lower. We don't think too low, but a little bit lower. But with the other weight bands, the other formulations, we were really close to adult values that you could expect. And if you then have similar pharmacokinetic exposure in the child in a certain weight band and a certain formulation, certain dose, then you can hopefully translate that to the same efficacy as you would see in adults. So that's very important to first reach that target, and then you can make an extrapolation and expect the same efficacy. A very important observation from that same Odyssey trial is that we showed that indeed if you give this adult dose of 50 milligram already to patients above 20 kilogram, that you get adequate trough concentrations of dolutegravir. And that was actually quite a surprise, because just calculate, if you give 50 milligrams, let's say, to an adult patient of 70 kilogram, and you give already 50 milligrams to a patient of 20 kilogram, that's a much higher milligram per kilogram dose that you give that particular child. But we learned that the clearance of dolutegravir in children really is much faster than in adults. So you have to give a higher dose, you get initially a higher peak concentration to end up with an adequate trough concentration. But we were able to show that it was also safe to do that, and then we could harmonize the rollout of the adult 50 milligram film-coated tablets also to be used in a large proportion of children. Later, in the same Odyssey trial, we did 2 other PK sub-studies, just expanding our experience with dolutegravir in these children. One study was on the children with the lower weight bands, so where we used the dispersible tablets, And the second was with the rifampin interaction, and that's the same as I presented yesterday. With the BID dosing of the pediatric formulation, you have the same exposure if you have rifampin on board versus standard dosing of dolutegravir without rifampin. So also published in Lancet HIV, our favorite journal, as you can see. And as I said, these PK data achieving the same exposure as you had seen in adults should translate in the same efficacy. And that was shown in the Odyssey trial as a clinical outcome, and that was published in the New England Journal, that dolutegravir was even better than the standard of care at that moment as a first or second line treatment. So that is really changing the uptake of dolutegravir worldwide. Now we have shown that it's even superior to the standard of care. And I strongly believe that by getting the PK first right, with the right dose, the right formulation, the right weight band, etc., that translated in this very good efficacy. And that was shown here in this graph, that in all different sub-studies, subparts, and follow-up of the study, you see an improvement with dolutegravir if you compare it to the standard of care. It was set up as a non-inferior trial, but it ended to be superior. Of course, this was not the only study that was looking at dolutegravir. We were very happy to collaborate with our US colleagues from the IMPACT group, the 1093. They started a little bit earlier with different formulations, but later on we really combined our efforts, and both studies, and I think that's quite unique, both studies contributed their own PK data, the clinical data, to the manufacturer ViiV, which then could compile a submission to the FDA and the EMA, and that led to the approval of the dispersible dolutegravir tablets. And now we're seeing slowly the global transition of children living with HIV to dolutegravir. It's a little bit early already to see many clinical data, published data, so I will show you a mix of some published data and some other program information. But this is a publication that already shows that when you look at the ART regimen, and this is more general INSTI, but that's certainly a large proportion dolutegravir, you see already an increase in the viral load suppression rates when you treat these patients with this class of agents. So this is all children in a large network in Eastern and Southern Africa. Another example of what is happening is from this program from CHAI. And this is not about viral load results, but this is about something else, which may even be more important than just viral load results. This is a survey to healthcare workers what their experience was with pediatric dolutegravir 1 month after they started to treat their children with dolutegravir. And you can see it's all very positive. So when you ask a healthcare provider about what the children say about the taste, about the side effects, how they look at the pill burden, or the ease or convenience of administration, the ease of storage, so not in the refrigerator, for instance, they all like it much better with dolutegravir. And you can imagine what the effect is. Healthcare workers like it, patient caregivers like it, patients themselves like it, and that is certainly something you really want to see. And at the end, you get a better patient adherence, and of course, at the end, a better virological efficacy. So this is also very good supporting the good virological results with dolutegravir. Another example presented at the Pediatrics workshop in Montreal last July, where you can see, and this is in a few African countries, a very rapid uptake of the pediatric dolutegravir. In less than 2 years, from a minority of patients to almost 80% of the patients now on pediatric dolutegravir. So you can see it can go quite rapidly. And I think that we should also, for this case, applaud for ViiV Healthcare that they really made it possible, collaborating with generic manufacturers to get dolutegravir available around the world as much as possible. So I think that is certainly something that really has helped in getting this achieved. This is a slide that is already second quarter of last year, so most likely it's outdated, but it shows you that especially the African countries have responded quite rapidly in procuring the generic pediatric dolutegravir dispersible tablets. And they are scored, so you can also give 5 milligram of that. And I think that Asia is a little bit behind. If you can see it here, maybe that has improved since then. But I think that this is really important to follow and to get as many countries starting to procure this. This is also a slide, I think, that was presented on Wednesday at the Pediatrics workshop here, an update of the countries here in the region, whether they applied for the registration, whether it was approved, or whether it was in national guidelines. And I must say that when I was looking at this, I found too many no's. So if I come back next year, I really hope that these no's will not be there anymore. You can see the examples of the countries who are doing better. We can learn from each other. We can learn from the African countries. So I really hope that this is going to change quite rapidly. Maybe one reason why countries or doctors, maybe the government is a little bit hesitant to introduce it is maybe they think, okay, this is data from Odyssey, this is from the US trial, what about Asian children? Well, we do have data presented at CROI last year, a study from HIV-NAT here, in collaboration with Tim in Chiang Mai, looking at the dolutegravir trough concentrations in these children. And for those who have been present yesterday, you all heard about the trough concentration of dolutegravir, which should be around 1 milligram per liter. And you can easily see that this is achieved in all of the weight bands with the various doses that were applied. So also in Asian children, why not? This is going to work if you achieve this adequate concentration. Okay, very positive. So maybe you say too positive. Is it the perfect drug? No, of course not. There is no perfect drug, unfortunately. And one concern already expressed many times during this conference is the weight gain. And of course, it's also important for children to look at that. If you look at the title of this pediatric cohort from France, they say there is no overall impact. But if you look at the table and you see the separation by age, indeed it is true that in the younger children there is no significant difference. But in the adolescents, starting from 10 years, you can see there is a small increase in BMI, a significant if you compare it to non-infected children. And that is also now confirmed in the US study here, where you can see an increase in body weight or BMI with pediatric dolutegravir, and the same as with adults. More be seen in girls than in boys. And this is about adolescents. So this is the same as in the French part, that in adolescents you see an increase in the weight gain. So I think the weight gain is some of the knowledge gaps we have in children. Is it a concern, mainly in adolescents? Maybe we're going to see other long-term toxicity. I think we still are waiting for some more data on the exact dose of dolutegravir in newborns, so neonates. There is a study ongoing in Africa on dual therapy. You heard about dolutegravir lamivudine for adults, but there's now also a pediatric formulation of dolutegravir and lamivudine dispersible tablets that's being studied. Whether dolutegravir is really better than PI-based second-line treatment in children, we have to wait for the CHAPAS 4 study, where the week 96 results hopefully will be presented in the summer of this year at the conference. And some more data will be presented next month at CROI on a TB treatment and dolutegravir in young children, in infants. Well, is there more to wish? I think there is. I would like to see more generic manufacturing of the dolutegravir dispersible tablet so that it will be becoming more available worldwide. I think we are going to work on pediatric fixed dose combinations, including dolutegravir, like we had TLD for For the adults, you cannot use the pediatric TLD because the TDF cannot be used in young children, so we need something else. That's part of the universal project. And you already heard something about the long-acting injectables, which in particular could be interesting for adolescents maybe facing the adherence issues, and maybe also the weight gain might be less with this combination. So that's something we are going to see in the future, I hope. So then coming back where I started, the comparison between the treatment guidelines. And now I think we really see something different. If you look at especially the older children, there is a 76% overlap between adult treatment guidelines and pediatric treatment guidelines. And only in the very young children, so less than 4 weeks, the newborns, there you can see there is 0%. So only in that small category of children, we are using different drugs than in older children or in adults. So I think this is really a major change if you compare it to my presentation from 2015. And I'm very happy that I now can make this comparison looking so much better than it used to be. So my conclusion is that I really believe that pediatric antiretroviral treatment has improved in recent years, mainly because of the introduction of dolutegravir as a once daily, well-tolerated antiretroviral, few drug interactions, and very important appropriate pediatric formulations. And I already mentioned ViiV to be applauded for their help in facilitating generic production. Of course, adherence issues remain in the adolescents. That's independent of the drug that you're using. And maybe there the long-acting injectables can really make a difference. With that, I will thank you for your attention. Happy to take any questions.